Hey, thank you for coming to the session. I'm in many ways going to pick up on a couple of themes that were expressed earlier. The architectural and planning one raised the issue of small and slow is one theme that came out of that. And then the other issue that Veronica raised, this issue of logs, Johanna raised logs a case. So what this curriculum experiment is about is actually turning that on its head. It's humanizing the curriculum, if I can just put it in a phrase. And the team involved is Hartman in the Eden District, Melanie Alperstein, who was a Twitter, Louis Jenkins in the Eden District, and Steve Reed, and that's a photo of a 2016 cohort of 6-year students. Just to give you a feeling of when we talk about far away, crossing boundaries, this is the zebra house between George and Oudtshoorn, so you can see how far away our 6-year medical students are from the metropole of Cape Town. It's about 5 hours. And here's a picture just to give you a feeling for that small. Here is one 6-year student at Oudtshoorn with a one-on-one supervision relationship in surgery in 6 years. Do you know how rare this is? Small is beautiful in terms of architectural planning, in terms of that previous thing. So very briefly, an introduction to this curriculum experiment that's happening in the faculty. It's part of a global movement to decentralize learning and training away from the academic health complex, from the big university, the big teaching hospital, highly specialized personnel with very complicated ill patients, and to take the learning and training closer to the communities that the graduates will serve at the end of internship and community service. And a main motivation is contextual relevance. If you take the students to where they're going to practice and they actually experience it, you get a more authentic and holistic experience for the students. But crucially, in terms of what we were talking about earlier in the previous session, they have the opportunity to explore and develop holistic care for patients experientially. So just very briefly, the outline. What this is different is we're taking 6 years and immersing them in the Eden District, about 5 hours drive from Cape Town. So they get a regional small town experience at George Hospital, which is a secondary hospital. It doesn't see patients as complex as at Critis Care. And then they get a rural placement at Oudtshoorn, which, as you saw, is quite remote. So that is what is different from the Cape Town 6-year students. These students volunteer for this program, and there are 2 electives, 4 weeks and 2 weeks. That's the same as the Cape Town students. The other thing that is very different, and this is where the curriculum is trying to build relationally, is looking at longitudinal and integrated learning, and those features are built in: continuity of learning, continuity of patient care, continuity with the community, and comprehensive care across all disciplines, integration, minimizing disciplinary silos. So you can see integration, care, and relationships are central to very deliberate planning of this curriculum experiment. Now I'm reporting on a research project. It's part of a much larger descriptive study, which is analyzing various dimensions of both the staff's and the students' experience of the 2 very different clinical training models, the Cape Town-based one and the Eden-based one. But today's presentation, I'm focusing only on the 2 cohorts of Eden students in 2016 and 2017. There was a pilot in 2015. And then what I did is I followed up the 2016 cohort as interns, and I did telephonic interviews with them during their internship. Qualitative methodology, just a quick run through. Mainly face-to-face interviews for this part of the study. Interviews are transcribed, and telephonic interviews. And please note, so the interns already have done the bulk of their internship by the time I get to interview them, so they've got virtually a year's experience to draw on. And the findings so I'll start with the 6-year cohort first of all. It's very interesting that the findings between the 2016 and the 2017 cohorts are very, very similar, almost to the same phrasings. And they do talk to each other, obviously. But what is significant and relevant to this conference is the needing to adapt to very different environments. They geographically, as I've indicated, they've had to move to remoteness, where the demography of the region and the culture is very different to metropolitan Cape Town, and they spend quite a bit of time talking about that. Organisationally, another boundary they're crossing, organisationally, they're moving to a much smaller hospital and even smaller at Oudtshoorn. And again, what is critical here is, in both cases, the question of medical hierarchy, and I think what Veronica was alluding to, those power relations, they are either more benign or they're a lot flatter between the students and their clinical supervisors in this context. So issues of power play out very differently. Professionally, what happens to them is that from day one, they're considered as a 6-year to be a member of a team. So you arrive and you join the team, you're respected, you're given responsibility, and you're trusted as that team member. And it really blows their minds. It's nothing like they've experienced before. Some find it unbelievably threatening in the beginning, intimidating, and they grow into it, and others run with it from day one. But the main kind of response they give is, I really have to rise to this challenge. This patient is my patient. I have to take care for this patient. I've referred to the hierarchical questions previously in the previous slide. You have benign or flat hierarchy. But crucially, they get a lot of hands-on clinical experience. So this business about logging a case, they've got logbooks, but they don't log cases. The discourse of the patients, of the student interviewee participants, is all about patients and people. It's a completely different discourse. No one refers to a case. So what we find in this curriculum experiment, and if I pull the themes together, is that there is professional inclusion from day one. And you come along as the 6th year. And it's encapsulated in this small team. We're in this together. We're learning relationally. And the students report a tremendous growth in confidence, self-esteem, and a sense of agency. They feel like they can take responsibility once they've got over their initial fear and terror of being put in that position. The other boundary they're crossing is they're transitioning from being a student, being 5 years of a medical student, to a junior doctor. And both cohorts reported they're grappling with long hours of service. So they start at 7 in the morning and they're supposed to finish at 4 or 5 in the afternoon, but then they have to study after hours. So they're doing clinical service, learning, plus academic learning. And then, as I've indicated before, they grapple with the amount of autonomy and responsibility given to them and expected of them. And in some departments, it's quite high, and in other departments, it's less so. And then what is interesting in this transitioning from being a student to a junior doctor, without exception, all of the interviewees refer to thinking far more consciously about the kind of doctor I want to become. I develop an ideal. And this is immensely helped by their immersion in this experience. They get a practical experience to see how the referral system works between patients who are referred from Oudtshoorn to George Hospital, what the different levels of care mean for the patient, the implications for how you have to manage the patient. So constantly they're aware of what's going on around the patient and the patient's environment. And so they can observe, when they're at Oudtshoorn at the district level in that rotation, they can actually observe how the patient's context influences their health, the social determinants of health. So they get a far more holistic perspective. They make comments like, when we were back in Cape Town, we'd get bussed into doing a clinic, and we've got our earphones on, and we're just sort of reading our notes, getting ready for the clinic. So they're not looking at the context they're being bussed into. I think this one quote encapsulates the sense of professional identity well. It's a number of the interviewees actually use the phrase developing a sense of social responsibility. But I think this ideal of what kind of doctor I want to become is really indicative of, I think, what this conference is about. And then another boundary they're having to cross in this process is they're having to adapt personally and socially. When they're asked what were your reasons for volunteering, overwhelmingly they're saying we want to get out of our comfort zone. We want to experience different environments. We want to learn to cope because we know that the public health system is a very challenging place to go and learn. They're concerned about being prepared for internship. And so these are some of the reasons they talk about in the way that they get out of their comfort zone, 5 hours away from Cape Town. They have to adapt to small town, limited leisure. And there is really limited leisure in the George Eden district. And they're not used to that kind of constraint. And then there is a critical issue of social exclusion. George's culture is in the center of, in the urban part of George, is essentially old apartheid style, white Afrikaner, and then on the outer suburbs are the settlements of other peoples, othered in George. So what we find amongst these student interviewees, these participants, is that they turn to each other for peer support. They share accommodation, they talk every night about their experiences clinically to help them cope with the academic enterprise. They talk about how they adjust. There were 2 very particular racial othering issues that emerged, which I can talk about in the discussion time. And this occupied the groups in the evening for a considerable amount of time, and they worked together through this as a group. They also have mentors, clinical mentors in the program, but most of them find external mentors as well. And these people are quite significant in helping them navigate these various adaptations and boundary crossings. So then I did telephonic interviews with the 2017 interns and asked, one of the questions I asked them is, what did you take away from Eden into your internship? And without exception, everyone talks about the confidence, the clinical knowledge and skill preparedness. I've just lifted out 1 or 2 quotes. And I think very interestingly, the third one, they all talk about social adaptability. But I think the one interesting quote is the one student who felt most othered in 2016 turned that into an experience about how she thought about her patients. Because when she entered the public health system doing her internship, like Veronica was mentioning, there are various ways in which health professionals interact with patients that are less than desirable. And she thought very hard about what this means for her and how she could use her own experience to think differently about herself as a doctor. Their professional identity, they left Eden with a very clear sense of what kind of doctor they would be. They could formulate it. In fact, we developed, which isn't part of this report this afternoon, but what their conception of a good doctor is, which is part of another presentation, and they all contributed significantly to that. And what they find is this is an ideal. Going into the public health sector as an intern is really challenging to hold on to that. What they also took from Eden in regard to the theme of professional practice and learning was resourcefulness. They had to learn that various parts of the country are very resourced, both in health terms and what ordinary civilians have access to. And I think the most striking thing was how many of them mentioned what a shock it was to go and practice in a province outside of the Western Cape, how completely different the health systems are in terms of the way they're resourced, the way they, from a staffing point of view, equipment point of view, the way the referral system works. There's a lot to be desired and elsewhere where they're placed in their internships. They've had to adapt. A significant adaptation for them has been the limited or no clinical supervision in some places. So where there are vacant posts, there's only a person 1 year ahead of you as the second-year intern or a medical officer. Some posts have, some departments have have vacant senior consultants. So clinical supervision is limited. They've had to adapt to a very different organisational setting, practices and cultures. As I indicated, the bulk of them refer to, and most of the, only one stayed behind in the Western Cape. All of them are distributed around, of the people I interviewed. For most of them, the referral system is not working. The effect of that is they have very high patient volumes, a great mix of patient issues, and very long hours, exceptionally long hours, longer than the professional committee's requirement for them. They find themselves in a very defensive working environment. They've come out of UCT, MBCHB, which this curriculum strongly advocates evidence-based medicine, and they find it's not practiced or appreciated, and they enter into these dilemmas. Thank you. They enter into these dilemmas very much that, like Veronica was suggesting. How do you start talking to the medical officer, or if there is a clinical supervisor who is a consultant or senior consultant, about a different way of doing things that is evidence-based when they've got to sign off your logbook, or when they've got to, basically sign off your logbook. The experience is, in some settings, there's been benign hierarchy, but that's in the minority of cases. Most of them refer to a negative hierarchy, bullying, intimidating, and they know that is quite a common thing because they're in touch with each other via WhatsApp, and I'll come back to the WhatsApp. And we also know that that's a global phenomenon. There's a whole literature on that. So having to cross all of these boundaries, in talking to them about how are they coping with these multiple boundary crossings, these adaptations they're having to do, because as you can see, it's a geospatial boundary. They're operating in rural tertiary hospitals, urban tertiary hospitals, hospitals that are supposed to be tertiary but that in fact take secondary and district level patients because the referral system's not working, and so on and so on. So it's very complex task and resourcing level variation that they've not had to deal with in the Western Cape at all. They're fairly experienced at navigating the negative power hierarchy. There's quite a bit of it around, but that's an issue they all refer to and lean on each other very strongly for. And what they find is a strong psychological and emotional stress level. In the early phases, every one of them without exception raised this issue. They enter confidently, they're looking forward to it. Eden has given them so much. They're really enthusiastic. And then there's this daily struggle to hold on to your ideal of what a good doctor is, because you see such different practices. And you work such long hours and you want to do more for your patient, but the resources are simply not there. So how do they manage this? And encapsulated in relational support, some of them have stayed as a WhatsApp group, and there's from sharing clinical protocols, how do you manage this patient? Have you seen this across the country? Through to how do you handle any kind of personal matter? Telephonic support. What has been really critical about that small team, slower pace in George and particularly Oudtshoorn is they formed quite strong relationships with some of their clinical supervisors, so they can simply pick up the phone and say, I need help. I don't have a clinical supervisor. This patient has presented with, I need help. We've got no guidance. And that's been frequently reported on. Many of them, fortunately, are still close to their families and draw on family relationships, and a number refer to religious or spiritual mentors to guide them through this process. So what I've been able to glean from talking to these people is how important developing relationships is to them. But what struck me was the smaller the hospital got, the more easier it was. And the more and Oudtshoorn, they really hold Oudtshoorn up as an exemplar. We go there, we are given so much responsibility, we're expected to do so much, but we treat it with such respect. We're given help when we ask for it. We treat it as a team member, and they rise to the occasion. As scared as they are about being left on night duty alone, they rise to the occasion and they feel that patient is their full responsibility. And so for this small group that I interviewed, the 2 cohorts and then the interns reflecting back on their experience, it was clear that that immersion experience, that small team experience, was formative psychologically and emotionally for handling this very difficult internship that they're in. And so they're learning to build resilience through these relationships, and that's the definition of resilience we've been working with in this project, and we'll be exploring in greater depth. Okay.